Don't be tricked by clinics that sell you a blood work for $100, but in reality, you're just getting a simple CBC, CMP, PSA, and testosterone. Yeah. It's basically like having the engine light of your car on, taking it to a mechanic and allowing him just to look at one part of the engine. And based on that diagnosis, they tell you if you're good. Now, our bodies are very complex and biochemically, we're very different.
Welcome, everybody, back to another edition of Beyond Biohacking Brothers Podcast. As usual, I'm here with my natural brother, Miguel, and my adopted brother, Dr. Eberwine.
Adopted.
So on our last episode, we talked a lot about hormone deficiencies, which seems to be an epidemic in our society today. And we talked about some of the effects and some of the causes, the whys, and why we're seeing this in our society. And at the end of the podcast, one of our recommendations was to get a proper lab, get a comprehensive lab, not a grandma lab, as I called it, which is what they typically give people at the end of the year as a yearly physical, and they tell them that they're doing fantastic. Which only covers the basics. If you want to live an optimized lifestyle and you want to overcome a lot of the assaults from EDCs and nutrient deficiencies that we're facing as a world today, you need to go deeper. And so we thought, what better way than to have our very own Dr. Rudy go over the typical comprehensive lab that we run on anybody that comes and visits us for the first time. So to kick this off, obviously, Rudy, I wanted to kind of go over a lab, all of us together. This is, for obviously we're going to protect our patients' privacy, but this is the typical person that comes to us.
But wait, before we even go into the details, let's talk to people listening how important that is.
Yeah.
Because you talked about the grandma labs, because the average person will tell you, I did my yearly physical, all my labs were okay.
Yeah.
And in their mind, they're like, oh, they checked everything, right?
I passed with flying colors.
Yeah. The average lab that's covered by your insurance that you get on a yearly basis covers maybe 25% of the markers that we have. So again, for people listening, yes, you want to do your conventional yearly physical exam. Let the doctor, listen to your heart, listen to your lungs, do the basic blood test, but it's not enough. It is not enough, and that's what we're going to cover today.
Yeah. To be exact, our blood work has 73 biomarkers. So a lot of people will hear out there, oh, my blood work has 50 biomarkers. Ours has 73. And when you hear that, for example, if you think of a complete blood count, you're talking about like red blood cells, white blood cells, right? They're counting each of those markers as biomarkers, which they technically are. And ours is 73.
73, that's a good
and
number.
by the way, the extra 20 are big time markers, right? They go layers deep. So anyways, we wanted to, obviously for the protection of our patient, we're not going to mention his name, and we'll have the labs up just with the numbers, but we just want to kind of go like what our typical consultation would look like in terms of explaining these things to you, which, Rudy does an excellent job at. And just for clarity, I want to let everybody listening know that this is the typical person that comes to us. They've gone to their yearly physical. They've gone to their expensive concierge doctor, and they told them that they're they're passing with flying colors, but they still feel like crap. And they don't understand. They're like, hey, I don't understand. I eat well, I eat clean, I exercise 5 days a week, and I'm still not able to make muscle. I feel exhausted all the time. And all of these, typical symptoms that we see. Right. And so let's just get right into it. Let's get right into it. So again, the first couple lines is usually what we start with, which is glucose, hemoglobin, A1C.
And let's start. So what I'm going to do, we're going to go almost in a systematic way.
Yeah.
And then we'll go the name of the test, and then we'll go, and then mostly the first test that we're going to go are what's included in a yearly blood test, what almost everybody gets.
Correct.
So maybe the first one we're going to talk about is the CBC, complete blood count, right? That's included in everybody's lab test. A complete blood count usually checks. There's a few important things. There's almost 20 markers in that because it checks almost every white cell that you have. But what's important, what we look as a physician when I look at a CBC, number one, it lists your WBC, which is your white blood cell count. Really important to know if you have an infection. If your white blood cell count is high, it may mean that you have an infection, an acute acute bacterial infection. And usually you'll see the type of cells that go up are your neutrophils. You can have a high white cell and it's your lymphocytes that are high. That may mean a more chronic or more viral disease. You can have an elevated white blood cell with things like leukemia. CLL, chronic leukemia, is one disease. The way you know that you have it, you have a white blood cell count. And then you look at the different cells, so the WBC. Then we look at the hemoglobin and hematocrit. This is the amount of blood that you have. Very important for us to see what it is, because one of the possible complications of TRT is secondary erythrocytosis, when you have a high hemoglobin and a high hematocrit. So we monitor those levels. Another thing that's really important in a CBC is the MCV, mean corpuscular volume. This is really important. If you have any abnormality in your hemoglobin, let's say you have a low hemoglobin, anemia, the next thing the doctor wants to know, what's your MCV? Is it microcytic, meaning low MCV, below 80, or macrocytic, above 98? Microcytic anemia, low MCV, below 80, usually it's iron deficiency anemia. Other things that can cause that would be things like sickle cell disease or sickle cell trait, any kinds of hemoglobin disease like thalassemia or weird disease. But the most common low MCV, low blood count is iron deficiency. High MCV with your hemoglobin, usually if you have an MCV of over 100, things you want to think about: number one, liver disease, alcohol use. Sometimes also low B12 will give you a high MCV, and thyroid disease. So if you have hypothyroidism, you may have this. There's a lot of other diseases. You can look at the MCV and it gives you almost how bad the disease is. For example, iron overload, which is one of my favorite subjects. When you have iron overload, you tend to have a high MCV. Low iron, low MCV, high iron, high MCV. And in hemochromatosis specifically, they showed that in MCV, the higher it is, the more severe the disease. So there is definitely things we can learn in the MCV.
What about polycythemia and secondary erythrocytosis? That's also in the complete blood count?
So that you'll see the hematocrit.
Yeah. So, and to talk about this really quick, we talk about secondary erythrocytosis, which is where testosterone stimulates your bone marrow to make more blood, and you'll see a high hemoglobin.
Testosterone-induced secondary erythrocytosis.
Testosterone-induced secondary. We also see primary erythrocytosis patients. So it's secondary, but secondary to high altitude. Patients who live, high up in the mountains, low oxygen, so you need to make more blood. Another cause of erythrocytosis, it's obstructive sleep apnea, and we get so many patients with
which is really cool, because I learned that from you, and now I tell people, hey, do you snore? When I see their labs, like, how do you know? So I'm like, it's right on your labs.
Exactly. So a lot of the patients will see, they're like, wow, their secondary erythrocytosis because of testosterone went so high so quick. There may be an underlying obstructive sleep apnea, and you ask those patients if they snore, it's worth getting tested, because undiagnosed and untreated sleep apnea is a big cause of cardiovascular disease, increased blood pressure, heart disease, aneurysm. So you want to know that. The other thing we see in the CBC is a platelet count. How many platelets you have. Platelets are for coagulation of the blood. If you have low platelets, it needs to be investigated. So those are the main things you find in a CBC.
Yeah, so I think we could say that, when we're talking about the CBC, this is like baseline safety, right? If there's something chronic in the CBC, that's something for us to look at and to say, hey, you need to get this fixed. You need to go to a specialist and get intervention on this. Or maybe it's, it's not as critical, but it gives us a picture of the future. If we're going to put you on a certain therapy, this is an area of concern that we need to watch more closely, because it could be affected.
Yeah. And the thing with CBC, almost everywhere you go and check, they check your CBC, because it's a cheap test. It's included in almost everything that you do. Actually, when you go and donate blood, they actually will do the little
finger prick.
No, they don't even do a prick. It's with a light, and they can estimate your hemoglobin.
Oh, wow.
Not even a prick. So it's a little light spectrum, and they can do this.
Well, that's the one they clip on your
Yeah,
finger.
they clip on your finger. So really easy to monitor a CBC. There's other things you can go deeper with a CBC, where you look at the CD4 to CD8 ratio, the CD4 type of white cells
That's for immunological response.
Yeah, that gives you an idea of your immune system. So that's a little deeper. In our VIP blood test, we're going to include this. So we'll do another.
Right, that's actually the one when we did a Ryan Smith True Diagnostic test. Our levels came out suppressed, it was a direct. The first thing that he asked was, were we taking rapamycin, which is suppressing our immune system, so we had to stop it. And genetically speaking, we just don't respond well. But
toxic for us. But
but the CD4, CD8, that's what you would check on a CBC. So CBC, very simple.
CBC is baseline.
Yeah, let's move to the next simple test, which is a CMP, complete metabolic profile. Right. So this is, again, a pretty extensive test that's also very basic, very cheap, that's checked at almost every doctor's visit that you have. And that has multiple biomarkers. The main one we look at would be the creatinine, BUN and creatinine, to look at kidney function. Sometimes a high BUN creatinine, you can calculate your eGFR, which is your estimated glomerular filtration rate, which is the kidney function, should be above 60. But you can have a high creatinine for dehydration. What I see a lot at our clinic, you see young guys with muscle with a high creatinine, because creatine is a muscle. It's in the muscle protein. So if you have high muscle mass, you can have a high creatine on your blood test. If you take creatine supplements, I see that a lot, that you have a slightly elevated creatinine. So in my mind, I'm thinking, does this person have chronic kidney disease because their creatinine is elevated, or is it dehydration, or because they're taking creatine supplements?
And I think this is an important subject, right? Because we grow up and we're in a culture of muscle building and all this stuff. And a lot of the guys that come to us that are already kind of advanced, they come, they ingest a lot of protein. This is where we try to educate people about the value of protein and how protein actually is synthesized in the body. But you'll see a lot of guys that use typical products like whey protein, where their BUN and creatinine are really high. Yeah. And so, the for the listener, the important thing about that is that over time, that can cause kidney dysfunction.
Yeah, and again, protein is great. We need protein for lean muscle formation, for so many things in the body. But like everything, if you take too much protein, it can cause kidney dysfunction. So, just like everything in medicine, it's almost a U curve. Too low, not good. Too high is not good. So it's finding the right balance. Other things you see in the CMP are the liver test. So that's where there are things like AST, ALT, a bilirubin, alkaline phosphatase. So all of those are usually liver function. So you'll get a picture of your liver health by looking at your blood test. Right. Something that's really interesting is then you can have almost full cirrhosis of the liver with normal blood liver test. It's not very, so it goes up a lot with acute hepatitis, with alcohol use, but sometimes when you have advanced cirrhosis or fibrosis, it's not even inflamed anymore. So your blood tests look good, but you do an ultrasound and you see a lot of liver inflammation. Another blood test that's not included usually in a CMP, but good for liver test, it's called the GGTP. That looks mostly for fatty liver. We include that a lot in our VIP blood test. It's not included in the basic CMP, but that's another liver test. CMP also you'll find,
which the other epidemic of insulin resistance and metabolic disease that we have in our society. It's huge.
So how many times do we do a blood test and we see a mild elevated ALT? ALT is more specific for the liver versus AST.
And the person has fatty liver.
But what's interesting, a lot of patients will come and tell us, oh, no, that's chronic for me. I've had this for a long time. My doctor told me, don't worry about it. I'm like, I don't agree. Anything out of normal, I need an explanation and I need a plan to make it better. And what do we do with those patients when they come with you slightly elevated? I ask them, do you drink alcohol? If you're drinking, you need to drink less because you already have liver inflammation. If you have insulin resistance, visceral fat, you're overweight, heavy metabolic syndrome, you'll have a slightly elevated ALT, which is likely due to fatty liver or some kind of liver dysfunction. And we can't just leave it like this. I need an explanation.
So it'll cut into your longevity for sure.
100%. all the patients with an elevated ALT or AST, I put them on a anti-inflammatory diet, lose visceral fat, lose body weight. Let's get you healthier and do an ultrasound of your liver. Because you can have pretty advanced fibrosis and your liver tests are normal or just mildly abnormal.
It's funny, now that you mentioned that, like it's the typical story, right? Like, oh yeah, no, I do my yearly physicals every year and I come out with flying colors. And then 1 year they're in the hospital and 3 days later they're dead.
Yeah.
Because of this, because they don't go deep enough.
They don't,
And they don't, it's fine. It's been chronic forever. No. I need an explanation and I need a plan to bring it down.
I
mean, we're focused on longevity, of course.
100%.
And for you listeners, when you hear the VIP blood work, we're not excluding anybody. If we wanted to test absolutely everything we wanted on a patient, it tends to be more expensive. And unfortunately, we want to make it as affordable as possible, but also watching out for your safety and making sure that we're looking for all the markers that are relative to your health and everything that has to do with your vitality and longevity. Because don't be tricked by clinics that sell you a blood work for $100, but in reality, you're just getting a simple CBC, CMP, PSA, and testosterone. Yeah. It's basically like having the engine light of your car on, taking it to a mechanic and allowing him just to look at one part of the engine. And based on that diagnosis, they tell you if you're good. Now, our bodies are very complex and biochemically we're very different, right? My brother and I have similar results, but we're different. Yeah. So we have to make sure that we look as many things as we can to properly diagnose you before you come on therapy, because obviously we prescribe testosterone therapy, but many times Dr. Rudy Everyone has had to send a patient to a hematologist, a urologist, a cardiologist, all forms of specialties, because he'll find something on the blood work that's an underlying concern prior to getting a patient on therapy. So when you hear the VIP, that's just for somebody who's been with us, who had some form of disease and really wants to check everything, or has had phenomenal results and really wants to go to the next level.
But for clarity, if you're a first-time patient, our comprehensive blood work will be deeper than 99% of tests that
for the past 12 years that I've been looking at blood work, I've never seen somebody with exactly our panels, close, but not with everything that we're doing. So I consider that we have one of the most specialized labs in our industry.
We haven't seen anybody with 73
biomarkers.
Yeah. We haven't seen
for this price point for sure.
Yeah, and that price point.
Yeah, for this price point for sure.
Which, by the way, our blood work, it's $385 right now, depending on inflation. But if you try to go through insurance, when patients are like, oh, no, just send me a script so I can go through my insurance, it could cost anywhere from $3,000, $5,000. I saw a patient in California got a $27,000 bill for the same blood work that we're charging $385.
Listen, Medicare charges $3,000 just for free testosterone alone. That's why free testosterone is not covered by insurance. $3,000
for what? For free tea?
For free tea.
But just free tea? No, but that depends on the insurance.
Medicare. So
that's great.
But anyways,
this is why our country's going bankrupt.
There's so many reasons.
The point to the listener is that this is, on average, a retail value of a $5,000 test that you're going to get for $385. But we'll discuss finances at a later point. But let's continue with this.
Let's keep going.
Yeah, let's keep going.
Now you've done in the CMP, you'll have your glucose also, and glucose is your blood sugar. Usually, that's the one we like to do fasting, and we like to see a fasting blood sugar below 100. Yeah, the 80 is where we want to see it. So that's one thing. So if go ahead.
No, sorry, finish. I'll add to the glucose
because the glucose is part of the CMP.
Right.
So now let's go. Okay, what else do we check? Usually for
but for the glucose, though, I was reading a study that for longevity purposes, keeping a glucose level under 85 gave you an extra 7 years of life if you were to consistently maintain 85 or below.
The only bad thing with this is hypoglycemia can be as bad or even worse than hyperglycemia. So yes, you want to keep it as low as possible, but especially for elderly people, if they're below 70, they're usually symptomatic. So finding that, always when you talk longevity, you have to see the study. You want to keep it as low as possible, but for elderly people, And again, elderly now it's defined at 65 and over. It's 10 years for me.
Right. What
You
I'm
don't
just
want
trying,
it too low.
what I'm trying to say, the reference range is 100, which we can also eventually go over reference ranges again and what they mean, because the population, who are they testing on, right?
Yeah.
It's 100, but ideally 90, 85 would be a better suited number, because it just tells us they're more fat adaptive. They're not utilizing so much glucose for energy, more fat.
So glucose, you want it usually optimal would be in the 80s.
Yeah, okay.
That's what you want.
This is one of my favorite ones, hemoglobin A1C.
Yeah. So hemoglobin A1C again.
Average report card of your glucose
The
levels.
one that you cannot cheat, by the way.
Actually, there are some people with how do you say that again? Hemoglobinopathies.
Oh, wow.
Hemoglobinopathy?
Hemoglobinopathies.
Every time I hang out with you, I learn
And
something new.
that's with the Haitian accent.
Hemoglobinopathy.
Imagine the Haitian French accent. So that's when you have any kind of disease with your hemoglobin. So sometimes, because what hemoglobin A1C is they look at the glycated product of hemoglobin. Glycated means that the sugar just damaged that molecule, and they look
Caramelizes, it oxidizes.
oxidize it. It's a reaction that happens even in our food. It gets brown.
Yeah.
That's what it's the glycated end products of hemoglobin.
Right.
And what that does when you check that, it's an average blood sugar about 3 months. So it should be less than 5.6. 5.6 to 6.3 is pre-diabetes. 6.4 or more is diabetes. So what we do to look at really your glucose pathway, we do a fasting glucose, hemoglobin A1C, and then we do a fasting insulin. And fasting insulin, same thing. Normal should be less than 18, less than 20. Optimal, we like it like that, less than 10, less than 8. And we see people, our people who are optimized, they come with an insulin level of 2.5.
4.
That says low.
Yeah.
We want it low. That said, I've diagnosed a couple of insulinomas in my practice in the past.
Does that mean they're low now?
It's a cancer that produces too much insulin. And those people have chronically low blood sugar, low, and it's usually arises.
But it's an outlier.
Extremely rare.
Yeah, it's an outlier.
Again, I've seen 2 in my 30-year practice.
What I've also seen is, typically, I don't know where I read that study as well. Also, maintaining an insulin level under 6 is almost like swimming with the current versus against the current. Meaning you're trying to lose weight, but if your insulin is at 20, it's going to be very difficult for you to lose weight because you're in a fat storage mode.
Insulin resistant.
But I was thinking to hemoglobin A1C, Doc, can you, just for the listener, because a lot of times, I'll see guys who are like, hey, I don't need any sugar. I don't know. Why am I in pre-diabetic conditions? Because, the level for pre-diabetes in this country is 5.7. So can you talk a little bit about that and what your perspective is on not being in the pre-diabetic mode, like
Definitely.
not accepting that as
and
normal.
we see that so many people, they're like, my diet is pretty good. Nobody eats a perfect diet, first of all. Second, you see a lot of people that have decent diet and they still have an elevated fasting glucose or A1C. So there's many things that go to your glucose control. So yes, your diet plays a big role. Genetics plays a big role. Alcohol plays a big role, and our favorite subject, EDCs. Actually, a lot of studies are now showing that endocrine disrupting chemicals, toxins in the environment, actually play a big role in adversely affecting our metabolism. So you see fatty liver, insulin resistance with things like BPA, phthalates, with the PFAS, those toxins that is in 97% of the blood tests. So they've done studies on kids that had high level of toxins in their body. And they see already at 8 years old, 9 years old, they're overweight, have fatty liver and insulin resistance. 8 years old, 6 years old, 10 years old. And when they compare their diet, I forgot the name of that study. I think it was called the Chico study in Southern California. They looked at some of the kids that were growing up in the area, high concentration of PFAS, the toxin in their blood. And they showed that those kids, when they had a high concentration of toxins, they followed them at 8, 9 years old. They had a big jump in their BMI and high risk of metabolic disease, like insulin resistance, high blood sugar, elevated A1C, abnormal lipid profile, abnormal blood pressure. because of toxins. So now there are so many things that can cause your A1C to be elevated. But again, we see so many people at the clinic who be like, oh, my A1C is always 5.8. That's chronic for me. And nothing I can do about this. No, we're going to fix this. Of course. Whatever it is.
And just to be clear, go ahead. Hemoglobin A1C is just so people get more clarity. The way I like to explain it, the higher it is, the more inflammatory, the more inflamed you are, the more inflammaging, the more you oxidize and your body breaks down. And since we're in an optimal, we're looking for optimal levels, we consider pre-diabetes sort of like being pre-pregnant. Either you're pregnant or you're not. Yeah. When we see pre-diabetes, to us, we look at it more like diabetes, although, again, it's considered pre-diabetes. It's giving you the red flag to slow down. We want you to make some serious changes so that level goes back to baseline.
Yeah, we don't want to accept normal. For the listener, if you're listening to this podcast, like, we want you to be exceptional. So, 5.7 is just not going to cut it. Not for us. I mean, we want to encourage you to get that.
4.7, baby.
We want to, we want to encourage you to get that below 5.5, right? Just for standardization.
I'm going to talk about iron overload again.
Well, before we go there, before you do that on the hemoglobin A1C, let's kill this one, because we've had people that are diabetic and they're like, it's impossible to reverse it. If you do the proper, depending on the individual, if you do the proper steps, you could actually become non-diabetic again, depending on the person, not everybody. I know
you don't even need to be that careful about it. Type 2 diabetes is a reversible disease.
Yeah, for sure.
Not type 1. Type 2 diabetes.
I'm talking about type 2. Yeah, type 1 diabetes, you don't produce.
It's a completely reversible disease.
Yeah, it's a lifestyle
with diet, lifestyle. Of
course,
we do it every day.
But even if it's like, it's been 20 years chronic, hemoglobin A1C of 16, there's some people that it's just, there's no turning back.
There's something called burned out. Right. Type 2 diabetes.
And it turns into type 1.
It not turn into type 1, but you become insulin dependent.
Right.
I'm going to tell you, I have a few of those patients in my primary care practice, and then you do a blood test that's called the C-peptide. C-peptide is to see if your body can still make endogenous insulin.
Right.
So I had a patient the other day, so it was in late 60s, has had type 2 diabetes with bad habits, genetics for more than 20 years. And we wanted to put him on a GLP-1. We checked his C-peptide level. It was low, meaning his beta cells weren't even making. So they say that GLP-1 usually don't work in patients like this. Well, I'm going to tell you, we put that patient on the GLP-1 medication. He still needs insulin, but he needs 1/5 of the amount of insulin that he was getting.
You can mitigate it.
So you can mitigate it.
Yeah. But it gives them a much better quality of life. Just that mitigating to that level, it's huge change already.
And no questions that having A1C or blood sugar at the lower limits of normal, as optimal as it's for longevity, it's for quality of life.
Of course. Everything
gets better. I'm going to talk about my favorite subject, iron overload. Yeah. Iron overload, it's a pure oxidant that causes a lot of oxidation, and it's a big cause of insulin resistance.
We're going to go there next. But
we'll do a full iron blood test another time.
But just to, and I don't want to beat this.
I feel like that's a whole different podcast.
But just on hemoglobin A1C.
Let's focus on iron some other day.
Just on hemoglobin A1C, just because I see this a lot. Look, you gym goers that consume a lot of whey protein. Let me tell you, a lot of you guys don't understand that whey protein turns into sugar if it's unused. You hear it again. Protein, your body is excellent at turning protein into sugar if it needs to. And so I see a lot of guys that consume a lot of whey protein with hemoglobin A1C of 5.7, and they're like, I don't get it. I don't even eat sugar. I'm like, well, that means that you're eating foods that are turning into sugar, because remember, all carbohydrates will turn into one thing, sugar. So, one of the effects of whey protein is that it'll turn into 84% sugar. So if you're consuming a lot of whey protein and you see your hemoglobin A1C, you have your answer. So that's one of those kind of lifestyle tweaks where you can remove that ingredient and lower this level.
Definitely. Okay, guys, we need to go to the next slide.
Yeah, I think so this is what Dr. Rudy was saying, that your typical CBC will stop at the ALT.
That's the CMP.
The CMP, I'm sorry. Mm-hmm. But then what we do is we take extra steps and we add things like iron, which is 5 different markers, and we'll touch shortly on that, because we'll do a whole podcast on iron overload. Dr. Zagini is on this.
Very few clinics check.
Very few clinics, which is one of the scarier.
Very, very.
Which is even scarier. And then ferritin, which is huge for longevity. It's actually one of the only confirmed longevity markers. B12 and vitamin D. So why don't we just go over those quickly?
So iron, we're not going to talk too much much about this.
We're not going to go
because
too
it's only been a year and a half that we started checking iron, TIBC, and ferritin, because I've realized the importance of iron overload in creating disease. And there are so many studies. We'll do a full podcast about this, but I encourage everybody listening to this, make sure, especially if you're on testosterone or if you suffer from low T, check your iron, check your ferritin. Very cheap, very easy to do, but not included in the typical yearly blood test.
And just for the listener,
even a hormonal blood test.
A lot
of them
and
don't.
for the listener, I mean, again, whether you're on testosterone or not, like you need to check your iron binding capacity, which is your TIBC, IBC, iron saturation, and ferritin. So it's 5 markers.
And then now let's go with the vitamin B12. So vitamin B12, it's a really, really important vitamin for multiple enzymatic processes in our body. One of the things more important, it's really good for the central and the peripheral nervous system. Low B12 is associated with peripheral neuropathy. When you have the numbness, tingling. If you take metformin, it can decrease your B12. Low B12 also causes low physical energy, brain fog, low mental energy.
Or metabolism.
Associated with more being overweight.
Actually, it's so powerful that I'll tell you, we've had many clients whose B12 is really crappy. And they're like, I don't need it. I just want the testosterone. You bump up their testosterone 3x and they don't feel it. And now you add the B12 and all of a sudden it's a game changer.
I always like to say it's related to the energetic benefits of testosterone. So you can have a guy with a high testosterone but a deficient B12 level, and the one with a lower testosterone level with a high, meaning not deficient, but like, let's say 1200 total T, and the other guy has 800 total T, but with a higher B12, optimal B12, he ends up feeling more the energetic effects and has better metabolic function.
Definitely. So B12, and also the levels, B12 is almost like testosterone. Normal B12, let's say at LabCorp, is about 230 lower limit, 1245 upper limit, almost like testosterone, right? So if you're 285, you're normal. So a lot of studies are showing anything below 500 and definitely below 400 is not adequate enough. And we see even like associated with Alzheimer's disease, Alzheimer's dementia in the long term. So elderly patients, it's actually one cause of acute delirium. So when you have acute delirium, like meaning altered mental status, being confused, they're like, check the B12. A low B12 is associated with less cognitive function. So you want to maintain B12.
And it's funny that a lot of the panels, like testosterone, B12, you know, the ranges are so far apart that, as we always say, it's kind of like whether you hit the bullseye or the outer edge of the target, whether you're 25 or 80 years old, you're normal, you're within the range. So what the hell does that even mean, right? Like, is that...
and I would say if your B12 is under 500, you need to supplement.
So again, when we do our interpretation of labs, I don't just say normal and abnormal. I said subnormal, suboptimal. I don't need to wait for it to cross the red line to say we have a problem.
I don't need
we
to
have a problem if you're in the less than 50th percentile. We like A+ in here.
Baby.
Everything is top of the class. Well, I know you guys weren't top of your class. Come on. Don't lie to me. I was top of my class.
Well, our standard, as we like to say, our standard is, hey, if you're 75 to 100% better, we're meeting the standard, because let's face it, not everybody's ever going to get to 100%. It's a living, breathing, moving target all the time. So as long as you're 75% of better than where you were 100% of the time, I mean, that's a huge change, right?
And even when we see those people, we're like, okay, you had 75, let's repeat in 6 months. We hope you 80%, 82%. And then we keep going. It's continuous
incremental changes.
improvement.
Incremental improvements. Your next one is vitamin D.
Vitamin D, and you want to check your vitamin D3. That's the important one. And, you know, there's enough studies. I think everybody has heard
like 300,000 studies. I mean,
on vitamin D and immune system and cancer and bone health.
3,000 physiological
think about like
effects in the body.
COVID infection. Like that's when vitamin D3 became like even in the consciousness of people who didn't think about it before, because the studies were very clear. If you had a low vitamin D, you had a higher risk of getting COVID or dying from COVID or having more severe COVID, because again, the immune system. So vitamin D3, we're not going to spend a lot of time. Normal is 30 up to 100. I like to see it between 60 to 80. One thing that I always say, guys, just like everything, I don't want to see a vitamin D in 120. Like too much vitamin D can definitely cause kidney stones, can ossification of your bones, can sometimes draw calcium from your bone. I've seen cases of hypervitaminosis D causing hypercalcemia, high calcium. So yes, you can definitely do damage if you take too much vitamin D also.
Well, but then again, it goes back to the bell curve, right? Too much or too little is a problem. One thing that I want to mention about it is that vitamin D research has been shown to decrease chances of cardiovascular disease, cancer, obesity, diabetes, depression, among many other things. And the last thing that most people don't know is that vitamin D is a vitamin when it hits your skin, but when it gets converted to 7-dehydrocholesterol, and then it hits your liver and it becomes calcidiol, which is 25-hydroxy vitamin D. That's a hormone. And then when it gets processed through the kidneys, which it comes, that's a thing I've been meaning to talk about. Eventually, it converts into calcidiol. So calcidiol, which is the one that we measure, is the most abundant, but the most active form is calcitriol, which is the one that your kidneys output. So it's a hormone, guys, and it has over 2,000 to 3,000, depending on how many genes is activating, but 2,000 to 3,000 genetic expressions in your body that help you physically, mentally, and in every shape or form you can imagine. So,
and for you guys listening, this is our geek right here. He likes to geek out about
and
all
it has been shown to reduce all causes of mortality. Vitamin D. So make sure you check your vitamin D.
Well, listen, I think that for the sake of time, and I was hoping to do this on one shot, but obviously it's not going to happen. But hey, listen, if you're a listener, you're actually getting a very deep consultation on what these labs actually freaking mean.
$200,
right? So that you don't have to go to a doctor and be cross-eyed like, I don't know what this guy's talking about, because most doctors won't really go at depth and explain to you what the value of these things are. So what we're going to do is we're going to cut it off here, and stay tuned we're going to do a part 2 on our next episode where we're going to discuss cholesterol, triglycerides, which is super important, and the misconceptions there. Things like homocysteine, thyroid function, which Doug is an expert about. Things like prostate, testosterone, growth hormone, and some of the other factors. The juicy part. Yeah, this is you basically got through the
screaming.
You're not dying.
Yeah, you're
going to survive. Now let's get you optimized.
Yep. Right.
So stay tuned for our next episode. We hope that you've learned a lot on this episode, and please, if you like this episode, make sure to follow us, share us,
view it, look at it, and share. Do everything you can with it,
so we can help more people like you. Yeah.
We need people talking about this.
Yes.
Yeah. And by the way, just so you know, if you guys do end up coming to see Dr. E, this is what you're going to learn with him. Like, we don't want to just get you on any therapy, but we want you to become autonomous and really become empowered by learning what you're doing and what your labs actually mean. You wouldn't buy a Ferrari and not ask what type of gas it takes. So why wouldn't you ask what the hell do your labs mean? Yeah. Right? And
great point, Miguel. And one thing I love doing with my patients, when we sit down, I have them bring their labs and I say, let's follow it with me. So that I want to educate the patient. So that next time you go see a doctor, you should ask, what's my CBC? What's my A1C? What's my creatinine?
I really love that.
To learn.
I really love that. And I've been present in a lot of your consultations. And what I really love is the way that you educate the patient. Be like, look, I want to teach you what these things mean. So, I want to make you an active participant in this process, because if not, you're just like a sheep taking medication. I want you to know. And hey, guess what? Because I kind of disagree with some of the things that you've been told before, I want you to go back to your doctors and ask them this question. And you know what? Those patients have, and they've come to me and they'll be like, you wouldn't believe the face on my doctor.
All right. Really good, guys.
So thank you so much. We'll part 2 of this episode will include the juicy stuff on optimization labs. Until then, stay tuned and stay healthy.
And God bless.